It is my pleasure and honor this night to have two eminent figures in the field of nephrology, electrolyte, and acid-base disturbance. We have Professor Riyad Said. He is senior professor of medicine and nephrology, Jordan University Medical School since a long time. And we learned a lot from Professor Riyad Said and from his dedication and attitude. Really, it's fantastic. And he deserves this award, ISN Pioneer Award 3 years ago. You deserve it, Professor Riyad. Professor Riyad enriched our academy for more than 9 presentations, 9 videos, and the last one was in the August this year. This night we have Professor Nagy Abdelhadi. He is Emeritus Professor of Medicine and Nephrology, Mansoura University. Always we like to meet him, and he enriched our academy by more than 18 videos and a lot of presentations. All the time I meet Professor Nagy, I'm always happy because he carries happiness and the best attitude that I have seen. I'm sure this night will be very rich by cases and interaction and discussing one of the very difficult issues. Usually we forget the basics of electrolyte and acid-base disturbance. When I was at Harvard Medical School since more than 10 years, they classify doctors and professors who know well electrolyte and acid-base disturbances as the real professors of nephrology. So I'm sure Professor Riyad, through his fascinating cases, will enrich our mind regarding acid-base disturbances in his way of interactive cases. So Professor Riyad will present the case, and then we'll hear from Professor Nagy comment and short comments and go ahead for the subsequent cases. Before starting, all our academy presentations are not supported by any industrial companies, and it is time for Professor Riyad to start sharing his slides. I'm going to stop now. Professor Riyad. Professor Nagy, would you like to say an introductory statement?
I'm very happy to be with you today, and welcome, Professor Riyad. And I expect this day will be a very productive day, inshallah. We'll have a good meeting.
Okay. Professor Riyad, please share your slides. Go ahead, please.
بسم الله الرحمن الرحيم. شكرا جزيلا دكتور حسين. شكرا جزيلا دكتور ناجي. What really my task today is going to be about acid base, and I'd like to spend some time about the concept of acid base and what we have in order to lay the ground for the case discussions. Okay, what's acid base here? That, as you'll see, we know that the acidity or alkalinity of any solution is determined by its hydrogen ion concentration. We know that acidosis indicates an increase in the hydrogen ion concentration. Alkalosis indicates a decrease in the hydrogen concentration. For the sake of discussion and solving problems, we have the hydrogen ion concentration equal 40 nanoequivalent, which comes to equal pH 7.4, and normal PCO2 is 40, normal bicarbonate is 24. Now, I put this slide here to show you what really the spectrum of the pH scale that we have from 0, which is the battery acid strong hydrophilic, and down to liquid drains, and in between we have the urine, we have the saliva, we have the pure water, and that's the range of the acid pH that we have from all material that will come to. Now, normal blood pH is in the range of 7.37 to 7.43, and we know it's a dangerous balance really to keep very tight scale, and that between pH 7.37 to pH 7.43 equal to hydrogen ion concentration between 43 up to 37, down to 37. Now the organism always we faces a daily acid stress. We have different kind of acid. We have the volatile acid represented in CO2 and daily production almost 15,000 millimole per day. And that comes from metabolism of fat and carbohydrate. And that usually releases CO2. And we know CO2 is converted to carbonic acid. This really been taken by the lung and we don't really feel it. And that's a big burden that the lung will take care. Then we have the non-volatile acid, which is the major thing for us, 60 to 80 millimoles per day, comes from metabolism of amino acid, cysteine, methionine, and arginine, lysine, all that really, sulfuric acid, phosphoric acid, and those should be eliminated by the kidney. So the kidney will take really the burden for removing that. Now, we know that the regulation of the blood pH is controlled by essential metabolism of for enzymes. 3 lines of defenses. We have the buffer system, which is instantaneous. We have the lung, minute to hours, and we have the kidneys, few hours. If you'll see there is a change here, the buffer will take the major thing, and then immediate respiratory system and the kidney. And we know that the kidney is a sluggish organ really to take care of this. What's the buffer system? Basically, buffer system in human body, extremely efficient, and different systems work all together at different rates. It takes only seconds for chemical buffers in the blood to make adjustment. Respiratory tract can adjust the pH upwards or in minutes by exhaling CO2 from the body. Renal system can also adjust pH through excretion of hydrogen ion and conservation of bicarbonate. Now, the buffer system that we have basically intracellular buffer and extracellular buffer, the intracellular protein and hemoglobin, the extracellular buffer phosphate, bicarbonate, and ammonium. As you'll see, each consists of pairs. Now, there are several buffer systems in our body, all of them, as you note, is state of equilibrium. We have the bicarbonate, we have the hemoglobin buffer, we have the phosphate, we have the protein, and the ammonium. Now, the intracellular buffer, which in all cells present when we exchange hydrogen ion for potassium, and that go inside the cells. In the presence of bone, usually hydrogen will go in replacement with calcium. And that's why acidosis most of the time induce hypercalcemia and bone resorption. Now, the protein as a buffer is the most important function in our body. Protein are made up of amino acid, which contains positively charged amino acid group and negatively charged carboxyl group. The charged region of these molecules can bind hydrogen and hydroxyl ions and thus function as a buffer system. Buffering by protein accounts for 2/3 of buffering power of our blood, and most of the buffering occurs within the cell. The second buffer system basically is the lung, where we have here the intracellular, extracellular buffer, phosphate. This is what we call the monosodium acid phosphate, and this is disodium alkaline phosphate. And this is the bicarbonate, which is the sodium bicarbonate and carbonic acids. As you'll see the Henderson equation, there is always a state of equilibrium between the pH, the kidney function, and the lung function. We have the bicarbonate represent the kidney and the lung represented by the PCO2. The bicarbonate acid buffer, when we have sodium bicarbonate plus a strong acid, this is the salt of a weak acid with a strong acid, will give us a weak acid plus the salt of a strong acid, which is a neutral salt. So that's what we have. When we have carbonic acid, which is a weak acid plus hydroxy strong base, it will give us bicarbonate, which is the salt of a weak acid plus water. And that's how really the buffer system will work here. Concerning the phosphate, it's exactly the same thing. When we have the disodium alkaline phosphate with acid, will produce monosodium dihydrogen, which is the acid phosphate plus the neutral salt. When we have hydroxide or strong base, the same thing will happen with taking the hydrogen ion, neutralizing that. So we have strong base converted into weak base. We have weak acid converted into water and CO2. Now the lung comes the concept of the lung. We know that the central chemoreceptor sense PCO2 and hydrogen ion, stimulation, ventilation, eliminates CO2, loss of CO2, volatile acid reaction favors capture of the pH. As we'll see, the respiratory center being stimulated through the hydrogen ion present here, and the hydrogen will be water and H2, and then the CO2 will be eliminated by the lung. 1,500 millimole a day is being excreted by this. Now, if we look about the buffer system concerning respiratory, when you have an increase in the pH, that means alkalosis that stimulate the brain and arterial receptors, suppress respiratory center, leading to increased PCO2 retention, leading to increased HCO2, carbonic acid, decrease the pH, so correct the acid base. On the contrary, if we have a decrease in the pH as a result of respiratory acidosis here, what will happen? Stimulation of the brain arterial receptors, stimulate respirators, hyperventilation, low PCO2, decreased carbonic acid, and increased pH. So that's the role of the lung really in this situation. The kidney, unfortunately, it has really double role. The two different nephron segments, reabsorption of bicarbonate that we filter every day, which occurs in the proximal convoluted tubule, plus the thick ascending lobe of Henle, and the regeneration of the bicarbonate that being consumed as a buffer. Now, if we look about our daily acid load, state of balance, we should be, we gain around 70 milliequivalent of hydrogen ion a day, so we have to get rid of that. So our daily acid production should equal our daily acid loss, which is talking about the fixed acid in this situation in order to have stable pH. Now, we know how much bicarbonate we filter every day, 25 milliequivalent per liter, 180 liters per day, that's our GFR, that will come to 4,500 millimoles of the bicarbonate being filtered. How much bicarbonate we have in the urine under normal condition? 0. So that's quite important. All that amount of bicarbonate that's being filtered, reabsorbed in the proximal convoluted tubule and thick ascending of Henle, very small amount will be in the cortical collecting duct. So under normal condition, we don't have bicarbonate in the urine. Now, how this really happened, which is quite important, bicarbonate is being filtered, which is water soluble, that's sodium bicarbonate. Now we have the sodium active pump that will put sodium into the cell, and we have the bicarbonate remained here. This is sodium hydrogen exchange pump. You have the hydrogen with the bicarbonate producing carbonic acid, and the carbonic acid will be dissociated with carbonic anhydrase into water and CO2. We know CO2 is a gas. It will go through into the cell with water, carbonic anhydrase. As you'll see, it will split again bicarbonate and hydrogen ion to continue the cell. Sodium will be absorbed and bicarbonate will follow. So by this, what we have here in the lumen of the renal tubules transferred into the bloodstream. This is, we call it bicarbonate reclamation. So that something belongs to us, we are gaining it back. We are not losing it down in the urine. Now the buffer of this, we need now to regenerate what we consumed on daily basis. Now the buffer of a large amount of acid between 70 to 80 millimole, it has to come as a free hydrogen ion. How it will come? We have two systems in our body, the ammonia, which is a gas, and then ammonium. That takes 2/3 of the acid excretion up to 40 millimole. And then we have the monosodium, disodium alkaline with the hydrogen acid phosphate. 1/3 of the burden will be taken, and that's what we call it titratable acidity. Now the bicarbonate that being present is very small amount. So the urine pH is indicative value, but quantitative negligible of amount of pH changes. Now, how this really works, the ammonium and the acid titratable acidity. As we'll see here, we filter phosphate, sodium phosphate, which is monosodium, disodium, one hydrogen ion here, and the same thing what we have in also with the ammonium, which is a gas that will come down to. With the active ATP pump, hydrogen ATP pump, you pump your hydrogen ion, it will join with the ammonium, will make it as a gas. Ammonium is a gas, will not go through the ammonia. But ammonium, once there is positive, it will come to the urine, trapping hydrogen ion. Now here, the monohydrogen or the alkaline, it will take one particle of the hydrogen ion to make it acid phosphate. Here, look about, there is one hydrogen ion being trapped here, so that will lead what we call titratable acidity. That's a very powerful amount of hydrogen being trapped. Almost 1,000 times can acidify the urine, this process. This is illustrated here. What we have, it is the lumen, and we have the hydrogen and secreted actively. It will join with the phosphate that we filtered in the urine. That's disodium alkaline phosphate. It will be converted into monosodium acid phosphate. In exchange with that, we have the gas, CO2 present in the cell with hydroxyl group here, carbonic anhydrase forming bicarbonate. Now the bicarbonate will go through into the blood stream. Do we have bicarbonate here? We don't have bicarbonate, but now we have a new bicarbonate, that what we call bicarbonate regeneration. And the same thing will hold like ammonia. The same thing with the ammonia. We don't have here hydrogen ion, bicarbonate, so all the bicarbonate will be a new one. That's really to rebuild what we consumed with the buffer system. Now, how the ammonia system really works, we know that amino acid glutamine through the glutaminase enzyme will form ammonium. Now, here the ammonium will be from the mitochondria into the cell, split it into two, ammonia, which is a gas, hydrogen ion. The ammonia will go through, because it's a gas, will be trapped with the hydrogen ion being secreted here, forming ammonium. Now, once ammonium is present, it will come down in the urine. Same thing, we have bicarbonate, it will go back into the bloodstream. This is the most important slide, really. We'll summarize all what we have. If we look about our daily intake of acid, up to 20, that's oral in the diet, in green, and we have loss of hydroxyl groups in the gut. So a net result will be positive 30 millimole will be added. And then we have organic acid being done here, around 40 millimole that will come here to the circulation. So the net result that we added from the diet and from metabolism will be 70 millimole. Forget about what we have here through the lung, 15 millimole, all of it will go through the lung without having any trouble, expired air. Now, the role of the kidney will come here, will filter, as I mentioned earlier, 4,350 millimole, and now this almost reabsorbed. Now, the ammonium, titratable acidity, and ammonium excretion will come in the urine 70 millimole. So what we have really between 30 here and 40 here, they come in the urine. So that will come as a net result of balance. And that's what we are keeping the pH in the range of 7.3 up to 43. Now, what's the pH? All of us, I'm sure, know that this is the Henderson equation. And what's the pH? It's the negative log of hydrogen ion concentration. And if we put this into a formula, we'll have Henderson-Hasselbalch equation. It happened by doing all this Hasselbalch equation, it will come to the pH of 7.4. How it really came into this, we know that the pK of this reaction is 6.1. Now the log bicarbonate over hydrochloric acid equals 6.1 plus log 24, because we know that the bicarbonate in the serum is 24, and we know the carbonic acid is 1.2. How we came to that? HCO3, which is the acid, equal its partial pressure multiplied by its solubility in the blood, 0.03. So 40 multiplied by 0.03 will be 1.2. So 24 over 120 over 1.2 will come as 20. And we know that the log of 20 is 1.3. Lot of mathematics. So it happened for hydrogen ion concentration of 40, we have a pH of 7.4. And that's the formula that Henderson-Hasselbalch equation. So basically the pH depends upon bicarbonate that directly related and inversely related with PCO2. If this increased, the pH will go up. If this decrease, the pH will go down, acidosis. Now, if this here increased, the pH will go up inversely, will go down, acidosis. If this decrease, that means alkalosis, the pH will go up. There are four, we know that: metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. This is the most important slide that really I'd like people to pay attention to. Changes in PCO2 and bicarbonate, they go hand in hand. If one increase, the other should increase. That's in respiratory acidosis. If this decrease in respiratory alkalosis, the bicarbonate should come down. In metabolic acidosis, if the bicarbonate, the primary decreased, this should decrease. If metabolic alkalosis, the bicarbonate increase, the PCO2 should increase. In attempt to keep the ratio 20:1, if we keep the ratio 20:1 between bicarbonate and PCO2, then our pH is going to be close to 7.4. Now, if we see divergent of this relation, this increase and this is decrease, that means we have mixed acid-base disorder. Now, the concept of the anion gap, which really is quite important for us. Now, that means we have cations equal anions. What are the cations in our body? Measured cations plus unmeasured cation equal measured anions plus unmeasured anions. If we rearrange the formula, measured cation minus measured anion that we have most of the time in our lab equal unmeasured anion and minus unmeasured cations. And that's basically the anion gap. So the anion gap is the difference between our measured cations and unmeasured anions. If we include sodium, we have sodium here, minus chloride and bicarbonate, should be 12 plus minus 2. If we add potassium, which is 4, so we have sodium plus potassium as cations, minus chloride, bicarbonate, anions will be equal 16. Based on this, we divide acid-base metabolic acidosis into anion gap acidosis and non-anion gap acidosis. It happened that how we develop metabolic acidosis, either we lose alkali from our body, and it happened that all these will be non-anion gap metabolic acidosis. And most of the time they are hyperchloremic. Now, addition of acids to our body will give us anion gap metabolic acidosis, and usually normochloremic metabolic acidosis. Inability of the kidney, the third one, either we lose alkali or we add acids, or we are unable to get rid of a normal acid load that we take every day, 70 milliequivalent. With kidney diseases, our ability of the kidney to get rid of the acid is, let's say, around 40. So we're going to have a build up of acidosis in our body. So inability of the kidney to get rid of a normal acid load. I'm sorry, what happened?
Go ahead, Dr. Nagy. The mic is
Okay. When we talk about the anion gap, it's very nice to have this diagram in front of us. The blue one represents the cation, and the other column represents the anions. Most of it is chloride, but we've got some of bicarbonate, and the anion gap is the just difference between both. And we can understand anion gap as sodium take away the sum of chloride and bicarbonate. Right. And if we put the unmeasured cation and unmeasured anion, we'll notice that the unmeasured anion, including the anion gap, which is not measured, of course, the unmeasured cation, the unmeasured anion is greater than unmeasured anion. And we can understand the anion gap as the difference between the unmeasured anion and the unmeasured cations. And we can use this formula just to understand and remind us with the causes of high and low anion gap. So anything that increases the unmeasured anion will increase the anion gap. And anything which increases the unmeasured cation will decrease the anion gap because there is a negative, a minus mark here. Anything that decreases the unmeasured anion will decrease the anion gap. And anything that decreases the unmeasured cation will increase the anion gap. So we can easily expect what increases and what decreases the anion gap. So what increases is any increase in the unmeasured anion, like higher anion gap metabolic acidosis. Any addition of unmeasured anion in the body, like lactate, like acetoacetic acid or sulfate or whatever, will increase. And anything that decreases the unmeasured cation will increase the anion gap, like hypocalcemia, hypomagnesemia, hypokalemia if we don't include the potassium in the equation, and hyperalbuminemia, which is an unmeasured anion. Okay, what decreases the anion gap is anything that decreases the unmeasured anion, like hypoalbuminemia, and anything that increases the unmeasured cation, like hypercalcemia, hypermagnesemia, and hyperkalemia. So any unmeasured cation here will cause a decrease in the anion gap. And this makes things very easy to understand. I don't want to ruin the lecture of Professor Riyad. I don't know if he will talk about serum albumin and anion gap. Shall I go ahead, or
Yes, go
shall
ahead, please,
shall
Dr.
I stop?
Sabi. No, go ahead, please. And then if Professor Riyad can go directly to the cases. Professor, we have now Professor Riyad.
Is he with us now? One important relation is the relation between serum albumin, which is very clinically relevant. We find a lot of cases with albumin change, hypoalbuminemia, especially with cases of liver disease, cases with nutritional hypoalbuminemia, and the cases with nephrotic syndrome. So there is a very intimate relation between albumin and the expected anion gap, and we should consider it in our mind when we try to solve a problem with acid-base conditions. So for every 1 gram per deciliter decrease in plasma albumin, anion gap is expected to lower be lowered by close to 2.5 milliequivalent to 4 milliequivalent per liter. So we can use this to calculate the expected anion gap with changes in serum albumin. And the converse is true for a rise in the serum albumin. When the effective blood volume is low, it appears that the valence on serum albumin is being more negative, so as if serum albumin is increased. So the correct anion gap for serum albumin, we put the measured anion gap and we sum it to 2.5 times the difference between albumin and 4. So 4 take away the measured serum albumin, and we get the corrected anion gap here. So we use this for our understanding of the change in anion gap. So it just will give us some examples of things that increase the anion gap. So if we have increase in the unmeasured cation, then the cation will expand, and the expand will be more in the unmeasured, and this will lead to some increase in the anion, but the increase here will involve chloride more than anything. So the anion gap will appear as if it is decreased. Like here in this condition, when serum sodium is 140 and the chloride changed from 106 to 114, bicarbonate from 24 still 24, and the anion gap decreases from 10 to 2, and the unmeasured cation from 12 increased to 20. So this explains how increased unmeasured cation would cause a decrease in the anion gap, only 2 like here. Here's some use of the delta gap. If the anion gap is more than 30, this will say that there is a high anion gap metabolic acidosis, even if the pH is normal. And if the delta anion gap equal, delta means a change from the normal anion gap. If the delta anion gap equal delta bicarbonate, then it is DKA. But if the delta anion gap is higher than the delta bicarbonate, 1.5 times, this might mean lactic acidosis. Or in other words, in lactic acidosis, you expect that the delta bicarbonate will equal delta anion gap divided by 1.5. So you can differentiate using the delta anion gap and delta bicarbonate if the patient has got a DKA or lactic acidosis. If it is in between, then you can expect it is a combination of both. You can also use the anion gap to diagnose hidden metabolic acidosis. When I diagnose a high anion gap acidosis due to lactic acidosis or ketoacidosis, I compare the predicted fall in bicarbonate based on the increase in anion gap. You have to extend that the decrease in the anion gap is the same as the increase in the anion gap is the same as the decrease in bicarbonate, because this occupies the site of this. So you compare it to the actual fall in bicarbonate. Then you use the following guidelines. A measured bicarbonate much higher than predicted by the increase in the anion gap is a clue that a hidden metabolic alkalosis may also be present. So if you do a measured bicarbonate and you find it much higher than what you predict by the increase in the anion gap, then this is a clue of a hidden metabolic alkalosis. But if you find that a measured bicarbonate much less than predicted by the increase in the anion gap, this is a clue that a hidden normal anion gap metabolic acidosis may also be present. So you can diagnose some hidden mixed acid-base condition, even if the pH and the other calculation doesn't tell you about that. And this is quite important in understanding the calculation.
Okay, that's
so
good.
What you do here is step-by-step diagnosis.
Okay, Dr. Nagy.
Thank you.
We have a normal non-anion gap metabolic acidosis, which is really loss of alkali. How we lose it? We have the GI system, diarrhea, pancreatic fistula, ureterosigmoidostomies, drugs, as you'll see here, the kidney usually, and others as post-hypercapnic. These are the things that we think about when we have non-anion gap hyperchloremic metabolic acidosis. And this slide, when we have anion gap metabolic acidosis, I think it has been shown by Dr. Nagy. I'm not going to repeat it, but ketosis, uremia, salicylate, methanol, aldehyde, lactate, ethanol, ethylene glycol, and usually lactic acid by exclusion. And that's anion gap normal chronic metabolic acidosis. What are the causes here as you see it? With ketosis, we have beta-hydroxybutyric acid, acetoacetic acid. With uremia, we have multiple organic, inorganic acids, salicylate, multiple organic acids, methanol, formic acid, paraldehyde, acetic acid, lactate, we know what it is, ethylene glycol, glycosidic acid, and oxalic acid. Then we'll come to the osmolar gap, the concept of the osmolar gap, where you have that mostly with alcohol intoxication, when we have the measured osmolality compared to calculated osmolality. We know that in our lab, we measure the plasma osmolality by depression of the freezing point, and the calculated osmolality, as you see here, sodium times 2 plus glucose divided by 18 if you are dealing with milligram, and blood urea nitrogen if you are dealing with milligrams. But most of the lab, they report also milliosmoles. So to make it easy, if you have a normal blood sugar and you have normal kidney function urea, you say sodium times 2 plus 10, and that will come almost to 290. That's our calculated osmolality. Now, when there is osmolar gap, that means it's more than that difference between the calculated and the measured osmolality. Now, and that's the osmolar gap. We have non-osmolar gap metabolic acidosis, and we have osmolar gap metabolic acidosis. And then we have the concept of the urine anion gap that we're going to touch on. So the urine anion gap, which is if it is positive, which means sodium plus potassium minus chloride, that's in the urine. Positive urine anion gap, generally between 20 to 90, and that's indicative of a normal amount of ammonium excretion, and that indicates basically distal RTA. If you have a negative anion gap, which is between minus 20 and minus 50, indicative of excessive amount of ammonium excretion in the urine, more than 80 milliequivalent, and it occurs mostly with metabolic acidosis generated by diarrhea. This is the map that really everybody should have it in his pocket, which is the acid-base map. You can fit any figures in this map. You can reach really a diagnosis if you are not going to go through the concept of calculation. And then, well, there is compensation. Now, every process in our body, there is a compensatory mechanism. If we have metabolic acidosis, how we compensate, the degree of compensation with the PCO2. We mentioned that PCO2, if bicarbonate decrease, the PCO2 should decrease. And now we know that arterial PCO2 should be expected to equal 1 point, for that's Winter's formula, 1.5 serum creatinine. Serum creatinine 12, that means the PCO2 should be 12 multiplied by 1.6 will be 18, plus 8 plus minus 2 will be almost 26. Or the arterial PCO2 should equal your bicarbonate plus 15. And then another easy way of doing it, really, looking about the last 2 digits of the pH should equal your PCO2 closely. So if you have PCO 25 millimeter of mercury, the pH last digit will be 7.25. Now with alkalosis, we have really the same thing, but in opposite direction. The bicarbonate, the PCO2 should decrease. When we have PCO2 increased, bicarbonate increased in alkalosis, our PCO2 should increase by 0.7 millimeter of mercury for every 1 milliequivalent elevation in our serum bicarbonate. Unfortunately, with severe metabolic alkalosis, you cannot exceed more than 55 millimeter of mercury, because when you hypoventilate, hypoxemia will occur, and we know that the respiratory center now will be more sensitive, and that will limit our degree of compensation. So you start hyperventilating. With respiratory acidosis, we have the acute and the chronic. For bicarbonate compensation in degree, when you have acidosis respiratory, 1 milliequivalent increase for each 10 millimeter of mercury increase in PCO2. That's acutely. In the chronic situation, for each 10 millimeter of mercury elevation PCO2, your bicarbonate should go by 3.5 to 4 milliequivalent. Now, respiratory alkalosis, that will be a little bit more pronounced. serum bicarbonate concentration will decrease by 2 milliequivalent for every 10 millimeter of mercury. That's an acute respiratory alkalosis. Chronic respiratory alkalosis, which means 3 to 5 days later after the disease, you have bicarbonate should really decrease by 5 milliequivalent for every 10 millimeter of mercury. So these all the calculation rules, rule 1, 2, 3, and 4 that we go to. I'm not going to go through this. We have to go now for the cases. I'll start with simple case, and then the cases will be really more difficult. And we can stop at any point really discussing the cases. This is a 60-year-old male patient with glaucoma, prescribed Diamox, which is carbonic anhydrase, by his ophthalmologist. A week into therapy, the patient became tachypnic, mildly confused, and suffered muscle weakness. And this is the set of blood gases that we have: pH 7.24, PCO2 25, bicarbonate is 10, and his potassium 2.5, chloride 114, and this is the sodium. Now, Dr. Hussein, how would you like really to proceed with this? What do you think? Hello?
Okay, Professor Riyad, I think this is a very clear case for
Okay.
the effect of acetazolamide or Diamox.
Yes.
Because this is the only diuretic that may be associated with acidosis, and all the other diuretics are associated with alkalosis. And I'm sure that you will clarify the concept now.
Okay, so really, just to solve this trouble, which is just an example for the more difficult cases, what really we'll do, we look about the pH. The pH is 7.24, that's acidemia. And then we have either this is metabolic or respiratory. We look about the PCO2. The PCO2, if it is more than 40, less than 40 here, it has to be just what we have PCO2 here, 25. If it is more than 40, that's respiratory acidosis. This is, in fact, it's low. So the second step, this is really quite clear metabolic acidosis. Second step, is it simple or mixed? So we have to apply Winter's formula. The expected PCO2 for this, our bicarbonate is 10. 10 multiplied by 1.5 plus 8 plus minus 2 will be almost 25. So the expected PCO2 is 25, and here we have our PCO2 is 25. So this is quite simple metabolic acidosis. Again, without this calculation, look about the last 2 digits of the pH, 24, and that's 25. So looking just on this, we say that this is simple metabolic acidosis. Now, third step, what's the anion gap? That we have to go systematically. Well, we know that the anion gap here in this patient is 12. So we are dealing with non-anion gap metabolic acidosis with hyperchloremia. So our diagnosis basically is simple non-anion gap metabolic acidosis. This is what the etiologies that I has mentioned, where we fit, I think we fit most likely with this category of drugs, that which is acetorazamide. Now, why the potassium? Then here we come to the potassium. Why the potassium is quite low? Simply because we are losing bicarbonate in the urine, and we know the bicarbonate is relative non-absorbable anions. It has to drag with it sodium and potassium. So hypokalemia is quite common in such situation. Now, what do we need really? It's just this is enough. We'd like to have more information about this patient. Hussein.
Yeah, I like to leave the mic to Professor Nagy.
Yes.
I think he has comments on this case. Dr. Nagy.
Actually explains the case very nicely. It's a common case actually when we use the acetazolamide or Diamox in cases of increased intracranial tension, in cases of glaucoma, and it produces such condition, especially if the patient has got mild renal impairment and he used a large dose of acetazolamide. Then you find it in few days the patient develops such a condition. It's quite common actually.
Yeah. So do we need any more information?
I think for this case we go for the kidney function.
Okay, well, to me, I would like to know what's the urine potassium and the urine pH. Okay,
Right.
because is this distal or proximal? We know that from the history. So we have, this is really the urine potassium, which is the cause of potassium loss in the urine, and we have urine pH of 5. So definitely we are not dealing with a distal RTA, we are dealing with proximal renal tubular acidosis, which is a drug induced. I put this case just to illustrate how we go step by step really for this case. It's Diamox related. I'd like to move to another more. Okay. Any comment about that case?
I think it's okay to go ahead.
Okay.
Yes.
Okay. This is more a little bit advanced case. 17-year-old girl fainted during ballet lesson and is brought to the emergency room. She gave a history of weight loss and amenorrhea, but claims to have been eating well. On examination, blood pressure on the low side. She's tachycardic. She has a short stature and lack of secondary 6 characteristics. This is her set of chemistry. We have BUN 27, creatinine is basically normal, blood sugar 78, sodium 136, potassium 2.5, and chloride, as you'll see, 81, and bicarbonate is 41. Her pH, this is the set of blood gases. By the way, we have here measured bicarbonate. We don't calculate it from the blood gases. We have it measured from the serum. Her pH is 7.54. Her PCO2 is 52. And urine pH, as you'll see this information in front of you.
I think.
Any comments?
Yes, I have a comment. If I apply your rules like the first case, so we are dealing with metabolic alkalosis, because here the PCO2 is high and doesn't explain the change of pH, so it is metabolic alkalemia, and we have chloride in urine is low, so this means contraction alkalosis or saline responsive alkalosis for the first lock.
Okay, so that's exactly what we apply. pH 7 more than 7.4, that's alkalemia. Our PCO2 is usually should be, if it is alkalemia, should go, the PCO2 is more than 40 or less than 40. Here what we have, our PCO2 is 52, so that's not a respiratory alkalosis, it has to be a metabolic alkalosis. That's step 1. Step 2, is it mixed or simple? We apply the same rule. What we have here, bicarbonate 41 milli equivalent, expected delta change in our PCO2, which is should be multiplied by 0.75. We know normal bicarbonate 24, so the difference is going to be 41 minus 24 multiplied by 0.75 will come to 12.5. So our normal PCO2 is 40 plus 12.5 is going to be 52. What do we have here? It's exactly the same value that present on the pH. So this implies simple metabolic alkalosis. Is this enough for us, or we have to go further step? No, metabolic alkalosis, we know two kinds, chloride responsive and chloride resistant. How we tell the difference? Then you should really look for your urine chloride. Urine chloride, we have it less than 10, chloride sensitive, more than that, usually chloride resistant. And so what we have here from this case is a simple metabolic alkalosis, chloride responsive. Etiology, I'm sure all of you got now to know where we stand. I put this slide here for you, the algorithm really for metabolic alkalosis. Look about the urine chloride. If it is less than 10 or more than 20 here, we're not going to talk about this part because that's really not the case here. So we have this cause chloride depletion, which is chloride, what will do? Gastric fluid loss, chloride wasting diuretics, post-hypercapnic, villus adenoma, chloride diarrhea, cystic fibrosis. All these will give you chloride responsive metabolic alkalosis. From the history that we have, This patient, she has weight loss, she's hypotensive, lack of secondary 6 characteristics. So basically, she's either eating well and vomiting, or she's not eating, some sort of to keep her figure because she's a belly student. Any comment so far?
Well, I think Dr. Hand got it. She wrote since the beginning of your differential diagnosis, eating disorders, bulimia, vomiting causes metabolic alkalosis. So she touched bulimia, purging. So I think we are in this spectrum. But let us see what the Professor.
I wonder if
Yes.
this patient has also been on some furosemide or something like that, because the urine sodium is very high. It's 100. What do you think about that?
She may, she may trying everything
Right.
in order to keep her figure. We know that
Because
diuretics
what
will
can
do that.
explain the high urinary sodium?
Thiazide, yes.
Diuretics
Maybe
and
thiazide.
the amount of bicarbonate. If you
Yes.
look about the amount of bicarbonate we have in the serum is 41. Her urine pH is so alkalotic that usually we have a good amount of bicarbonate. It's dragging with it sodium in order to get rid of these two, in order really to have a neutral electric balance in the urine between the anions and the cations. She's wasting potassium and she's wasting also sodium.
Dr. Riyad, you have a question here on the chat.
Yes.
Why mention short stature in this case?
Short stature?
Yes.
Well, this is part of her. That's part of her anorexia nervosa or bulimia nervosa.
Okay.
Is it clear?
Okay, if it starts from the early beginning of her life, it's okay.
And the lack of secondary 6 characteristics, short stature, hypotensive, all that.
Okay.
So really, this is bulimia nervosa mostly. It's bulimia nervosa. It's basically binge eating. They eat and a good amount of food, but they are really vomiting that. In addition, is an appropriate compensatory behavior to prevent weight gain, including self-induced vomiting, misuse of laxative, diuretics, enemas, excessive exercise, and fasting. As Dr. Nagy really mentioned about the use of diuretics. What do we have? Usual tachycardia and hypotensive. We have this in this patient. Xerosis, dry skin. If you look about their teeth, usually there is erosion of the enema, dental enamel layer because of the acid that being lost every day. And we have impaired fertility. They have menstrual dysfunction, oligoamenorrhea or amenorrhea. So really, this fits the bulimia nervosa. Any question?
Dr. Nagy, do you have any comments on the case?
I think this is quite clear case.
It's clear, yes.
Okay.
But it is a good exercise for us to consider the differential diagnosis, and if we go step by step, we can easily.
I think
have
that's my message. If we go step by step, we can, from the top, you can really diagnose, but really,
and never forget the history, the clinical history from the patient.
Yes. And you have question here, Dr. Riyad.
Yes.
Do you treat her, or this is a virtual case?
Well, this should be really treated by psychiatrist.
Okay.
Psychiatric evaluation.
So the first step is to give fluids and stop hydration because
normal sodium chloride.
Yes, it is saline responsive alkalosis. So we should give sodium chloride, isotonic saline, or because she is hypotensive, and it seemed that she is dehydrated, very dehydrated. So we give fluids, and then we assess her psychological aspects with psychiatry.
I think so.
Yes.
I think so.
Okay, we can go ahead, please, for the next case.
This is the 35-year-old woman brought to the emergency room in coma. Her sister states that she has had progressive weakness for the last couple of months. Physical examination revealed blood pressure 110/60, generalized areflexia, but no other abnormalities were noted. This is her blood gases. pH 6.88, PCO2 40, PO2 95. Look about the sodium, look about the potassium 1.5, chloride 118, bicarbonate 7, and her glucose is 110.
Okay. Dr.
Comment.
Nagy, do you like to comment, Dr. Nagy?
Yeah, it's clearly look like a case of hypokalemia with severe metabolic acidosis reaching to a life-threatening level of high acids in the serum. So it's one of the causes of metabolic acidosis. We've got to think of renal tubular acidosis, an important one, but we also have to think of diarrhea, the other cause, or something like that. So we have to look at the urine pH and the urine anion gap.
So if we go systematically, the same thing that we have severe acidemia. Is it really metabolic or respiratory? If you look about the PCO2, the PCO2 is 40, which is absolutely normal value for absolute, that's for its face value. So at least we say there is not primary respiratory acidosis. Look about, I mentioned primary, not primary respiratory acidosis. So if it is not primary respiratory acidosis, should be the other category, metabolic acidosis. Second step, is it mixed or simple? Look about the expected PCO2. Our bicarbonate here is 7. 7 multiplied according to Winter formula by 1.5 plus 8 plus. So expected PCO2 should be maximally 18 to 20. That's appropriate for this degree of bicarbonate. But look about her PCO2. Her PCO2 is 40. So this patient is unable to breathe. This patient having, in addition to her primary metabolic acidosis, a respiratory acidosis. So she has mixed metabolic and respiratory acidosis. Though the serum, the blood gas PCO2 is a normal value. You have to look, if one decrease, the other one should decrease. Our bicarbonate is 7. Our PCO2 should be low, not 40, should be 30, could be 20, but the fact now it's really maintained at 40, that's divergence of the norm, and that indicates immediately we are dealing with a mixed acid-base disorder, metabolic acidosis and respiratory acidosis. Now, what about the anion gap? Then we look about the anion gap here. The anion gap here, it's 135 the sodium, minus 118 chloride and 7 bicarbonate will be 10. So are we dealing with non-anion gap metabolic acidosis? And that means bicarbonate loss. That's not addition of acid. We have a decent kidney function. So this patient is losing bicarbonate. So the diagnosis here, non-anion gap, mixed metabolic acidosis, and respiratory acidosis. Now, why this all happened? That's we have it, but we have to look about the etiology. Thoughts?
This is in the chat, urine ion gap, and I agree with this with Dr. Muhammad Shuman to start urine ion gap because it will give us a very practical hint. If we find it's positive or negative, we can make our thought. So
urine anion gap.
Urine ion gap, and then urine osmolar gap or ammonia, because it may carry some toxins like toluene or something like that. So
okay,
let us go.
So etiology, look about here. This is at least from the non-anion gap metabolic acidosis. Again, I'll put it here to look at. We don't have diarrhea, we don't have GID, we don't have evidence of drugs at least. We have kidney disease, could be. So what you really need here now is urine pH, urine PK, urine potassium, and urine anion gap. That's okay. What really was being asked about the chat. Okay. What do you expect the urine pH to be? Any comment about from my colleagues?
Dr. Nagy, would you like to comment?
Yeah, if it is diarrhea, then pH might be a little bit increased. If it is renal tubular acidosis, according to the type, whether it's distal or proximal.
Okay, so let's see what we have. Urine pH is 6. Urine potassium is 40 milliequivalent per liter, and the anion gap is positive 25.
So we have now positive urine anion gap in the
Yes.
presence of normal anion gap acidosis. So we are maybe RTA, as Dr. Hind and others wrote in the chat, or maybe a surprise, and I am waiting the surprise of Professor Riyad, because it may be the end result of toluene poisoning that presents with this cocktail, and I'm waiting the results, Dr. Riyad.
Okay, so now look about the urine pH is 6 in a patient with bicarbonate of 6 or
Yes.
7. That means there is a good amount of bicarbonate in the urine,
Okay.
and that's losing. If it is proximal, we should really, according to what we have, we know that the renal handling of bicarbonate, TM maximum of bicarbonate 25, and it will come down, should conserve all the amount of bicarbonate that we filter.
Yes.
Here, in spite of having this very low urine pH serum bicarbonate, we still have an alkaline urine. That's by itself will tell us we are dealing with distal
RTA. Okay.
Which is with the anion gap also, urine anion gap goes with distal RTA. Now, the urine potassium is quite low. The urine is high in face of
severe
serum
hypokalemia.
potassium 1.5. So this patient is wasting large amount of potassium into her urine. So we have non-anion gap metabolic acidosis, bicarbonate loss via the kidney, urine pH is 6, potassium 1.5, positive anion gap. So this is distal RTA with profound hypokalemia. How bad, I'd like to ask someone, how bad this serum potassium level?
It is very bad because we have double acidosis.
Very bad.
Yes, we have a critical, as Professor Nagy mentioned, we have double acidosis, severe acidosis. This means that the patient doesn't have potassium in his body.
That's exactly.
Total depletion of intracellular.
Can I just have a comment here?
Yes, please.
This represents a tiring off of the respiratory system.
Yes.
This means the respiratory center is now fatigued, and the patient is passing into respiratory failure soon unless he is promptly treated, and he should be admitted to the ICU as soon as possible. This patient is a very serious condition because the accumulation of CO2 points to the impending respiratory failure in this case.
100% I agree with you, Dr.
And this is a very practical as well, because if I treat this patient in ICU, I should give potassium before thinking of acidosis.
I think nobody should think about treating acidosis.
Yes, treating hypokalemia first. Yes.
If we really give her bicarbonate, imagine that with this pH,
the patient will be
potassium level is 1.5. If I correct the pH up to 7.2, her potassium level will come down to each change in the pH by 0.1 will change potassium by 0.6 in the opposite direction. فبالتالي what we have, her potassium will be 1.5 minus 1.2 will be 0.3. This patient is totally depleted from potassium.
Yes, she will be dead. Yes.
No treatment for acidosis now.
Yes.
Now, this really will put complete respiratory failure, as Dr. Nagy mentioned, and this patient basically, will require something to help her. So the acute respiratory failure that we have is due to muscle paralysis secondary to hypokalemia. PCO2 is 40. That means that's it. This patient is fatigued. She's no longer really moving her accessory muscles, her diaphragm, not centrally, because really there is no muscle power. It's totally paralyzed from the hypokalemia. So the hypokalemia is the cause of her acute respiratory acidosis. Intensive care, yes. No bicarbonate, yes. And intubation. This patient required intubation. She was ventilated. I'm not going through the etiologies. This patient ventilated with a massive amount of potassium that she was given, up to 40 milliequivalent per hour, because her total body deficit of potassium is close to 500 or even 600 milliequivalent of potassium, knowing that our total body potassium is 50 milliequivalent per kilogram body weight. And if this lady around 70 kilos, that means 3,500, she lost almost 600 milliequivalent. That's total depletion.
Okay.
So the final diagnosis is mixed acid-base disorder, metabolic acidosis, distal RTA, respiratory acidosis secondary to hypokalemia, induced muscle paralysis.
So I think it's a very interesting case, Professor Riyad. And here the clue was in the urine pH, which was
Yes.
alkaline, that doesn't match with proximal RTA, as you mentioned, because we have limit in proximal RTA. If there is severe acidosis, we expect that the kidney will conserve bicarbonate. So this is the classic case of distal RTA with severe hypokalemia and acidosis. Treating hypokalemia is mandatory with this rate, huge rate, that should be given in central vein with monitoring the patient well. And this is the rate of writing is 40 milliequivalent per hour with frequent monitoring of the patient. I'm not careful about the rest of differential diagnosis because we have questions in the chat about the cause of coma. Is it explained totally by acidosis and hypokalemia? Whatever, we should correct all these points and then supporting the patient. And we can if we have time, I think
the pH, Dr. Hussein, the pH was 6.88.
Yes.
That by itself can induce coma.
Okay. Severe acidosis?
Severe acidosis, 6.88. And mostly it's the respiratory component that really caused her trouble. If this patient PCO2 was 20, her pH is going to be around 7.15. She's not going to be in coma.
And I think this will be the effect of ventilation. It will adjust rapidly these scenarios, and giving this amount of potassium, I think it will solve the issue of potassium. Do you have any comments, Professor Nagy, to be added?
My concern is about the dose of potassium to be given in this case. This case is lacking potassium very much. I mean, she might be deficient of something like 2,000 millimole of potassium from her body. So she needs the replacement with a very high dose. Might reach something like 40 milliequivalent per hour of potassium. And you've got to give it in a steady state infusion in a central line in a good concentration. And this will help also to replenish the volume.
That's exactly what has been done. Potassium up to 40 milliequivalent per hour infused through central line.
And I think one of the teaching point here for all my colleagues in nephrology, I don't like the style of writing 10 milliequivalent potassium and that's it every 4 hours, 6 hours. No, potassium in the critical illness in ICU should be written like this. How many milliequivalent per hour should be written clearly. And one of the key messages, we shouldn't give potassium with glucose, because glucose will stimulate insulin if the patient is not diabetic. And this
more hypokalemic.
Yes, the patient will be. This is why we stop Cadalex, because Cadalex is a fluid potassium in glucose. We stop it completely from our center. These are the 2 points. So excessive amount of potassium, 40 milliequivalent per hour, given in central vein, and monitoring potassium every 1 or 2 hours until the potassium goes to accepted level. And ventilation, I think ventilation will solve the issue of PCO2, will reduce PCO2 to cope and to improve pH, because if pH is improved, I think the conscious level
will wake up.
Yes, yes. We can go ahead for the next case, Professor Riyad. Yes, please.
Okay, there's another one here, a 6-year-old woman, history of essential hypertension, admitted to the hospital after 7 days of vomiting. On physical examination, she appears ill. Systolic blood pressure is 110 seated, 70 millimeter of mercury trying to stand her up. Pulse rate while seated 120. Abdominal examination reveals rebound tenderness and no bowel sounds. This is her lab. Sodium, her potassium 3.2, chloride 80, creatinine 1.5, bicarbonate 11, blood sugar 110, and arterial blood gases pH 7.2, PCO2 24, and that's what's the most likely acid-base disorder this patient has.
Okay. So I think if we apply, if you ask me, this is a
Yes.
clear metabolic acidosis because we have pH is very low and we have
Okay.
high anion gap acidosis. So it is high anion gap acidosis with vomiting. So if we calculate anion, delta anion gap to delta bicarb, we may even catch a combination of high anion gap acidosis with metabolic alkalosis with this hypotension. So I'm waiting your analysis.
Okay, let's go on. The same schema.
Yes.
pH is less than 7.4, that's acidemia. PCO2 less than 40, so that's primary metabolic acidosis. That's what we have. Is it simple or mixed? Quite clear, really, from 25, pH 27.25 plus 2 digits of PCO2 is 24. So to me, immediately, this is going to be simple metabolic acidosis. But let's go through the winter formula. The expected PCO2 in this patient, 12, our bicarbonate is 12, multiplied by 1.5 will be 18, plus 8 will be 24, plus minus 2, 26. So what do we have here about our PCO2 is 24, between 24, 26. Really, there is no much difference. So at least there is no respiratory alkalosis here or acidosis. So it looks like, at least for its face value, as primary metabolic acidosis. Now, what's the anion gap? Look about the anion gap here. 140 minus 80 plus 12 will be 48. I think I really heard Professor Nagy mentioned when you have such abnormal anion gap with some bicarbonate left in your area, you should really think about something else. It was illustrated nicely by Dr. Nagy. So we have anion gap here, metabolic acidosis.
With metabolic alkalosis.
Well, it's okay. Now we are going to see. That's it. So we have anion gap of 48, and still we have serum bicarbonate of 12. That means our starting bicarbonate, not really 24 or 25, we started with a high bicarbonate in order to, with all these anions added, we still have bicarbonate left. So there is a discrepancy, as we heard from Professor Nagy. So what we want to do now? So there is hidden something. We know that there is no respiratory component, either alkalosis or acidosis. Do we have? Listen to the history. Here the history is quite important. As we mentioned earlier, Dr. Nagy mentioned also, this patient for 7 days been vomiting. So when we vomit, we lose acid, hydrochloric acid, and we induced, the common cause will be, in this case, metabolic alkalosis. Do we have hidden metabolic alkalosis? Here we come the role of delta. Do we have? Yes, I think we should. Now, look about delta change in the anion gap versus delta change in our bicarbonate. The delta change in anion gap, 48 minus 12 will be 36, divided by 12 will be 3. That's the delta change in bicarbonate, 24 down to 12, that's 12. So we divide the delta change in the bicarbonate and the anion gap over the bicarbonate 3. Anything more than 1.5, with this, it indicates metabolic alkalosis. Any comment about this?
Yes, I have a small comment here. So the delta anion gap here is critically clear, very clear from the beginning that there is mixed metabolic alkalosis with high anion gap acidosis. I would like to add because there is a formula, summation of delta anion gap plus bicarbonate, if it exceeds 32, in a case of high anion gap acidosis, this means that there is as well metabolic alkalosis. Here, delta anion gap is more than 32 without adding bicarb. So it is clear metabolic alkalosis plus metabolic acidosis. And you mentioned clearly the cause, the reason is vomiting in this case. And then we can think of the etiology of the case after this. Anion gap causes plus the vomiting. So we correct the vomiting and then search for the cause of anion gap acidosis.
Okay. Then, so what we have, the diagnosis is a mixed anion gap, metabolic acidosis, and metabolic alkalosis.
Okay.
Now, it's clear that the metabolic alkalosis here, why the anion gap metabolic acidosis, and why the metabolic alkalosis. What other information do we need now?
So if we apply, so metabolic alkalosis is because of vomiting, and then the anion gap metabolic acidosis is now we should search for the etiology.
Okay.
And you both the causes, mud piles or cosmoles or whatever. We go osmolar gap is essential because osmolar gap will divide the causes of high anion gap acidosis into alcoholic and non-alcoholic causes.
Okay, we'll come to that. Now, we have the urine chloride. At least we'd like to know what's the metabolic alkalosis first. We know that this patient has been vomiting for a long period of time, 7 days. So our urine chloride is quite low, 10. So we have chloride responsive metabolic alkalosis, and that goes really with the clinical history that the vomiting is the etiology of this situation, at least one part, which is the metabolic alkalosis. I'm not going to go through it again. It has been illustrated in the previous slide in previous case about metabolic alkalosis, vomiting, GI losses. Now, what the etiology now of the anion gap metabolic acidosis? Look about this patient. This patient been vomiting, she's dehydrated. Look about her blood pressure seated and dropped down to 70 when some attempt to allow her to stand. She's tachycardic, so she's hypoperfusing. This patient having hypoperfusion. Now, this is the etiology of the anion gap metabolic acidosis. We know that ketosis, uremia, salicylate, methanol, paraldehyde, lactate, and ethylene glycol. We don't have any history of toxicity. We don't have history of drug intake. I'm not methanol, ethanol, or aspirin, salicylate, and others. But by exclusion, this patient has lactic acidosis because of the hypoperfusion state that we have. Any comment?
Dr. Nagy? So I agree with you, Dr. Riyad, but I'd like to hear from Professor Nagy.
Actually, when you just have the delta more than 1.5, you should think of lactic acidosis.
Okay. And
we have it. That's, yes.
And I think this is application to what Professor Nagy mentioned in the beginning.
That's true.
The use of delta to diagnose where we are. And the presence of shock, because one of the attendees wrote on the chat, shock, yes, shock may
that's
be
true.
Hypovolemic or maybe septic shock. So lactic acidosis may be...
It's a hypoperfusion state.
Yes. Okay.
Now, so we have here severe dehydration, hypotension, poor tissue perfusion, resulted in what we call here type 1 lactic acidosis. Not type 2, at least we don't have evidence of sepsis so far in this situation. And how we treat this patient? Quite simple, any dehydrated patient. We should, hypovolemic patient would be with normal sodium chloride. This would take care really of two components, the metabolic alkalosis, which is chloride responsive, and will take care also of the perfusion state, and all our lactate in the body will be corrected and converted into, later on excreted down, correct the acidosis that what we have. So the final thing about this patient is major thing about delta, and the anion gap when it's quite high, higher than what you expect, as we heard, you have to think about this as a mixed acid-base disorder, metabolic acidosis, and alkalosis.
Did you measure lactate in this case? Or
no, really, no. No,
So-
it was clear. It was really clear, Hussein, that
Yes.
the poor tissue perfusion, the hypovolemia, all that, it's really immaterial at that point in time.
But I think ill lactate is easily measured, and I think
Yes.
it is
Oh,
to be
we have
measured
it.
to
It's
be
available,
sure.
but
Yes, yes. Okay. And for the bicarb, another teaching point here, using bicarb should be very cautious in the presence of lactic acidosis, because it may disturb even respiratory center and maybe associated with hypoxemia and the calcium disorder. So we should be cautious whenever we decide to give bicarb for severe acidosis due to lactic acidosis. But
There
here,
are
because
certain guidelines on the use of bicarbonate in
yes,
cases of lactic acidosis,
yes,
and the threshold is even higher in cases of DKA.
okay,
DKA, the threshold is even higher than that.
okay. So
So only if the pH is below 7.1
even
or the patient is impending respiratory failure, then you start thinking of giving bicarbonate cautiously.
cautious
I agree.
monitoring both serum calcium and oxygen saturation.
I think even around 7, pH of 7, that you can really allow it to go. Don't give bicarb, because all your keto acids that is accumulated with our beta hydroxy or the acetoacetic acid will be converted into bicarbonate. So don't really need to give unless your pH is less than,
Seven.
something.
Yeah, with
Seven.
some exception if the patient has got some respiratory problem.
Yes.
Sure.
And if we decide to give, we should monitor the patients seriously.
Yeah.
Okay.
But the message here is hydration, hydration, hydration.
Okay.
That's really the message.
So we can take the last case.
Yes.
Yes.
That's just an 18-year-old boy, high school student, evaluated in the emergency department because of confusion, nausea, headache, and decreased vision after camping trip. Now it's clear, really, everybody will think, wow, we have the case. Patient friend state that he became ill 14 hours ago. Look about his chemistry: urea, creatinine, sodium chloride 100, potassium 4, his bicarbonate is 12. Now, serum blood sugar is okay. Forget about the osmolality now. Serum ketone negative, serum lactate 0.7, arterial blood gases 7.29, PCO2 26. What really ingestion of the following substances this patient may have: ethanol, isopropyl alcohol, methanol, or salicylate. So, and I think from the history, everybody will say, well, that's what we have, yes. And I think I agree with them if they are chatting that methanol is the cause. But how we reach really this? My point is the systematic
Osmolar gap.
approach.
Yes. It is high anion gap acidosis. It's a case of high anion gap acidosis. And then the osmolar gap is the tool to divide them into alcoholic and non-alcoholic. And the presence of ocular disturbance is within methanol intoxication.
I think this is the message, really. Every piece of information that you have, it will count. The history, the findings, don't ignore any single lab data that you have. We go the same way. We have metabolic acidosis, and always I love really to go with steps. And it's simple or mixed here. Look about our PCO2 is 26, our pH is 7.29, not that bad. So almost equal. Winter's formula will tell you bicarbonate multiplied by 1.5 will be 18 plus 8 plus minus 2, 26, and that's exactly what we have. So our expected PCO2 is 26, and that's the calculate the actual measured PCO2. So we have simple metabolic acidosis. Now, what's the anion gap? Look about the anion gap here. 140 minus 112 will be 28. Okay, so we have an anion gap metabolic acidosis. Anion gap metabolic acidosis. Now, this is enough? No, we have more information here. You have to calculate now the osmolality. What's our calculated osmolality? We have sodium times 2. Our sodium is 140, okay, times 2, plus urea plus sugar divided, that will come to 291. If you just say sodium times 2 will be 280. We have normal sugar, we have normal urea, and that will give you 290. So that's the calculated osmolality. Let's look about the measured osmolality by depression of the freezing point. It's 326. So what's the osmolar gap? Here you have the measured osmolality minus calculated osmolality will be 35. And we have it 10. So what we have now is simple anion gap, metabolic acidosis with osmolar gap. That's really the sequence of events that when I'd like to go with acid-base cases.
And the presence of ocular disturbance is
Yes.
methanol, and if we have stones or calcification, this may be ethylene glycol associated with stones or calcification.
So that's the diagnosis.
Yes.
Now, which one? And we know that this is really what will give you an ion gap. Okay, yes. So you take any one from these, you have it. Alcohols usually will do that. Methanol will do it. Salicylate will do it. So in the question, we have 3 or 4 of things that usually encountered here. But what will give you from this ethanol, isopropyl alcohol, methanol, salicylate? What will give you anion gap acidosis, and what will give you osmolar gap acidosis? Here really you have to fit among the 4 here. Let's look gradually. Salicylate. Salicylate will give you anion gap acidosis, but it will be mixed. It's usually, most of the time, it's a mixed acid-base disorder. Mixed metabolic acidosis and respiratory alkalosis. Yes, it's an anion gap acidosis, but usually it's not an osmolar gap.
If you allow me, Professor Riyad, because I would like to add a point for salicylate intoxication.
Yes.
Sometimes salicylate intoxication may even lead to normal anion gap acidosis or even negative anion gap acidosis, but the majority of cases is high anion gap acidosis, because sometimes salicylate is interpreted by the machine that we have as chloride. So it can lead to pseudo hyperchloremia. So if we have a patient who presents to the emergency department with disturbed level of consciousness with acidosis, acidosis and negative anion gap, we should measure acetylsalicylic acid in the blood, because we may pick up salicylate intoxication. Yes, okay.
So really what we have, salicylate will give you the mixed acid base, it will give the anion gap, but usually it's not an osmolar gap.
Yes.
So this has been excluded. Now, what about isopropyl alcohol? It will give you increased anion, it's an osmolar gap, but usually non-anion gap acidosis, because we have acetone. Okay? So that has been ruled out. Yes, it is an osmolar gap, but it is non-anion gap metabolic acidosis.
But so I think it is not 100% ruled out.
Yes, to some extent, at least for its face value, it's not the commonest thing among the other that we have in the differential.
But the clue is a clinical. You mentioned the ocular disturbance, and the methanol is metabolized, I think, to formate, and the formate has ocular toxicity, as I remember.
Yes, we're going to show that. And then what about ethanol? Ethanol, yes, it will give you osmolar gap. It will give you anion gap. So it is really both. It may fit here. Usually it's not that severe unless it's associated with lactic or alcoholic ketoacidosis. And again, in yellow, as I put, there is no visual disturbances with ethanol. So by exclusion, what's really left for us, methanol, will give you anion gap acidosis, will give you increased osmolar gap, and will give you decreased vision due to optic nerve toxicity. So from this here, simple anion gap, metabolic acidosis with osmolar gap fits well with the history, with the eye changes as methanol, red alcohol.
Yes.
So this is here, the answer for the question, it's in yellow. That's usually what we have. How this happened? Now we know that methanol is metabolized into formaldehyde, into formic acid, that will cause eye problem, hyperemia, blurred vision, blindness due to formaldehyde. And formic acid will give you the anion gap acidosis. How you treat this patient? If you look about this, I found this slide here. Ethylene glycol, which is the antifreeze, methanol, they are metabolized by alcohol dehydrogenase, methanol into formaldehyde, and the other drug will be glycolaldehyde. And then we have aldehyde dehydrogenase will make formaldehyde into formic acid, causing the ocular toxicity at one point and the acidosis. And then here, the ethylene glycol, the cycle will be glycolic acid, and then it will continue its cycle crystals into form of oxalic acid. The treatment of such individuals, we should really stop the rate limiting enzyme here. And that's how we treat them with ethanol, alcohol. The idea is ethanol. You block this because the has a preference for the ethanol and then methanol and the other one. So if we block this cycle here, all the toxicity of the drugs can be blocked. And then
yes,
we have the rate limiting step is the metabolism of ethylene glycol to glycol. Inhibit use, that's by using the fomepizole, which is atizole. Yes, atizole, relatively non-toxic, but it's quite expensive. Dialysis usually can help in such situations. And this I put for you some of the urine crystals that you may see in the urine analysis of such individuals. All these are oxalic acid crystals. And if acute kidney injury developed in ethylene glycol and you have a kidney biopsy, that's what I think what you're going to see, and that's what Dr. Hussein mentioned, you're going to see some oxalic acid deposits within the kidney.
This is why in the Western community,
yes,
they replace the ethylene glycol as antifreeze by isopropyl alcohol in the majority of cases. So nowadays, it is not the preferred antifreeze in the Western community.
And it's cheap. You can have it from any place, from gas stations, and that's it.
Okay. Dr. Nagy, would you like to add any point here?
I think what we do now for this case, we see a lot of cases actually with methanol toxicity. I don't know why. Maybe by cheating for the alcohol.
It's cheap because it's cheap.
Cheaper, and it's more available for commercial use. And we treat these cases by dialysis actually, and they produce very good results.
I agree. We do dialysis, yes.
Unfortunately, some cases lose their vision permanently.
Mm-hmm.
In the past, I read in our box that we can add ethanol to dialysate. I'd like to hear from you, Professor Nagy, about this point.
I have no, I haven't get any experience in that. But okay. I don't think we have to do that, especially if the patient has got some degree of unconsciousness.
Okay.
Or if he is acidotic, because this will add to the brain depression and the acidosis. But dialysis is very efficient in removing the methanol. And 1 or 2 or maximum 3 sessions might improve the problem.
It's more effective really in ethylene glycol more than also, if you catch it early.
Right.
Okay.
Any question about this?
So it is very nice cases.
Okay, if we don't have anything, I'd like just really, no case, but I'd like to show you something. Okay. What are the gaps that you know, Hussein?
There are many gaps because I have a presentation since a couple of years in NephroAlex about gaps in nephrology. So I'm aware by many gaps. So would you please go ahead?
I'm just putting this slide just to be sarcastic. What I know, we have the serum anion gap, we have the osmolar gap, we have the urine anion gap, we have basically the urine osmolar gap. Any other gaps?
Yes, there are. Dr. Nagy, would you like to add gaps?
No, I don't have any other gaps actually.
No, there are.
Okay, let me show you this.
Yes.
That's the generation gap.
Oh.
That's dad, and that's his son. Look about the gap.
Right.
Okay.
That's baldness, and that's shaving. So that's really generation gap. Okay?
But I know other gaps rather
Okay, tell me.
no. I prefer to go to my commentary because I have a couple of slides and then to have some comments from
I'd like to
professors.
conclude really, Hussein,
Yes.
if you allow me with this
Yes.
slide.
Please.
Life struggle, not against sin, not against money power, not against miscellaneous animal magnetism, but against the hydrogen ion.
Yes, I agree with you 100%. I'd like to hear from Professor Faissal Shaheen because he wrote in the chat that he has some cases of alcohol intoxication. Dr. Faissal.
Thank you.
Okay, thank you very much, Professor Riyad. Dr. Faissal, do you have experience with, as you wrote in the chat?
Yes, thank you very much, Prof. Riyad. I enjoyed the talk very much. The case is excellent, and it is a teaching cases for all of us. I would like to just give an experience of ethylene glycol, which happened with us probably 15 years back, 20 years back, with some rumors from the people that it can, the old oil from the car, which come out from the car, they can wash their hand with it and vitiligo will disappear. That's why I had a couple of cases which have poisoning, acute kidney injury, and it was mainly due to the ethylene glycol. Because this dirty oil, it contains antifreeze, which is the ethylene glycol. I document this case a long time, and it was probably at that time, probably I published it, and I got help of my professor from outside about the diagnosis. I sent the sample there, and they diagnosed the case. It is poisoning due to the ethylene glycol. So just I share this experience with you and the other colleague about what's the effect of the dirty oil when it is used to, they got used to treat vitiligo. Thank you.
Okay, let me, Faisal, so long you are with us, I was really planning to comment about something. I remember when I came to Taif, we have a case that the first time in 85 or so, we have a case of ethylene glycol toxicity. So at that point in time, I asked about alcohol. Alcohol, I need alcohol to treat this patient. Everybody was really surprised. And they were wondered what I'm going to do with that. وكان ممكن يقيموا علي الحد يا فيصل. But finally they got the alcohol when they knew really what we're going to do. And we used alcohol for the treatment of ethylene glycol at that point in time. That was in Taif 85 or 86.
So I thank you very much, Dr. Faissal. Do you have any points to add?
No, I think it is in 85, and I published actually this paper about ethylene glycol induced acute kidney injury. It's at that time, it's a long time back, but it was a rumor. Usually we cannot just go the rumor of between the people that vitiligo can be treated with this dirty oil, and the people were washing themselves with dirty oil in order to get rid of the vitiligo. And I'm sure Prof. Hussein also, when he was in Taif, because it was at that time, 85, 84, it was common between many people at that time. Thank you.
Thank you very much, Dr. Faissal, for your valuable comment. And if you allow me, I have 5 minutes or so just to add some points to this very nice gathering and very rich material, and we learned a lot from Professor Riyad Said. And one of the key message is no acid base without electrolyte. So it is, we should know all these dilemma. And one of the key messages is to go step by step. If we go step by step, we will not miss the diagnosis. So I would like to add from this very recently added to the literature, assessing acid base, because it touches my concept. Since 4 years, I'm advocator of some points I'm going to clarify. For normal acid base, as shown clearly from the beginning of Professor Riyad's presentation, we have the base and the acid, and they are in harmony, no abnormality. Serum bicarb is normal, pH is normal, everything is fantastic. But for acidosis in chronic kidney disease, we have, we can say it occurs in succession. So in the beginning of chronic kidney disease, we still have the kidney with proper buffering system and the secretion of ammonia, because kidney buffers acidosis. One of the main mechanisms is secretion of ammonia. So if we have excess acid, kidney compensate by excess ammonia to keep serum bicarb within normal. But this is not a normal state. We have excess acid and excess buffer from the kidney to keep bicarbonate within normal. And if bicarbonate is within normal, it will be in the low normal range. So if you have early stages of CKD and we find serum bicarbonate is 22, this means that we don't have acidosis in figure, but we have real acidosis with compensation with excessive ammonia generation. Excessive ammonia generation by the kidney is toxic to the kidney, with increasing fibrosis and the progression of CKD, and increasing the generation of renin-angiotensin system and the other bad mediators. And after the failure of full compensation, we'll start to have low bicarb, but pH is still within normal. If we are very late, we can find both low bicarb and the low pH, so it is acidemic hypobicarbonatemic. So this is a very nice diagram, shows clearly the term of bicarbonatemic or subclinical metabolic acidosis. We can detect it if we find the patient with the early degrees of CKD, serum bicarb is in the low normal. If we measure urine anion gap, we will find it clearly negative because of excessive ammonia generation, and you can measure ammonia to document. So if we believe in this concept, then we will advise the patients from early beginning to have fruits, vegetables, and potassium. And the fruits and the vegetables, it's not only for potassium to protect the kidney, but also it is basic diet and with reduction of acid load. So by this way, we can manipulate acidosis by diet. And and after that, we can add sodium bicarbonate. So this is the diagram. From the early beginning, we have acid accumulation with subsequent progression of CKD, and the risk will be more manifest with advancement of CKD. Another interesting point is regarding the alkalinization to treat metabolic acidosis or not. In chronic kidney disease, it's better to treat CKD-related acidosis, either by manipulating diet or giving sodium bicarbonate. And there is a very nice concept about sweet spot or the best value of serum bicarbonate that can be put in MCQ question. The best value of serum bicarbonate is between 24 to 26 milliequivalent per liter. Less than 24 in CKD patient to 22, this is a normal bicarbonate, but really there is increased acid and the risk of CKD progression. And if we treat acidosis to high level of bicarbonate above 26, this will be associated with many problems. So this is the figure showing that metabolic acidosis can lead to disturbance of cardiovascular system, mineral bone profile, muscles, sarcopenia, and insulin resistance. So acidosis is bad guy to be corrected to the sweet spot, as I mentioned. The advantages of treating acidosis is retarding progression of CKD, improvement of insulin resistance, improved in muscle mass and nutritional status, because I learned it since the early residency to improve malnutrition in dialysis by checking acidosis. Acidosis is associated with malnutrition. And when I assess patient on dialysis or in CKD and there is acidosis and malnutrition, I should correct acidosis first before thinking of supplementing this patient. improvement of secondary hyperparathyroidism, mineral bone disorders, and bone density, endothelial dysfunction. All these are improved by bicarbonate or manipulating diet to achieve normal bicarb in CKD. The problems is bicarb therapy may increase FGF23 and phosphate level, and may increase the risk of vascular calcification, and there is some possible adverse effects like increasing blood pressure, although it is debated, especially if we restrict the chloride intake. This is why I mentioned sweet spot to keep bicarb less than 26, between 24 to avoid a progression of CKD, and less than 26 to avoid vascular calcification. The last point, the euglycemic ketoacidosis, euglycemic diabetic ketoacidosis, that is famous, and I presented it in my presentation about diabetes. Sodium glucose cotransporter 2 inhibitors are considered a magic bullet, as I mentioned, as Professor Tariq Elbaz mentioned in his elegant presentation, that sodium glucose cotransporter 2 inhibitor is recommended by the current KDIGO if estimated GFR is above 30 as 1A for treating diabetic and diabetic kidney disease. But the question, does the use of sodium glucose cotransporter 2 inhibitors associated with the development of euglycemic DKA because of glucoretic effect? It seems this is the very recent commentary on systematic review that was published last month. This is the question. In patients with type 2 diabetes, does sodium glucose cotransporter 2 inhibitor increase risk of diabetic ketoacidosis? In the original systematic review, the author reviewed 39 trials, including large number of patients, 16,000 patients. And as you see, although the risk is very low, but it is significantly different from the control from placebo, that SGLT2 inhibitors may be associated with increased risk of euglycemic ketoacidosis. And this is another case, should even single dose can be associated with euglycemic DKA that can persist even more than the expected half-life of the drug. So this is why we should be aware of patients with high risk of euglycemic DKA. Why SGLT2 inhibitors are associated with euglycemic DKA? Because they reduce insulin and increase glucagon. And this cocktail will increase lipolysis with the development of ketones. This is why we should be vigilant and educate the patient. If you are treated with SGLT2 inhibitors, the patient should be stable in eating. If there is any problems and the patient feels nausea, vomiting, undue fatigue, he should come to us and stop the medications. Because, and in this scenario, we measure serum ketone bodies, or if serum ketone bodies is not available. Why serum, not urine? Because SGLT2 inhibitors increase reabsorption of ketone bodies. So if you test urine, you'll find false negative results. This is why we can check, it is an easy to check blood gases. If there is high anion gap acidosis in the presence of glucosuria and normal plasma glucose, it is a case of euglycemic DKA because of SGLT2 inhibitors. And in this scenario, we stop the drug, we give glucose and insulin. That's it. And the highest risk for euglycemic DKA is surgery operation. This is why we should stop them 3 days before surgery and don't resume SGLT2 inhibitor except after be sure that the patient resume the basal state. So physicians should refrain from using SGLT2 inhibitors. This is another important added message. If the patient has been diagnosed to have euglycemic DKA, please, no need to resume SGLT2 inhibitors. The last point, even starvation can lead to euglycemic DKA. As Professor Riyad mentioned, we should take good history because history may be a clue for the diagnosis of our cases. I'd like to stop here from any comments. I'd like to appreciate the efforts done by Professor Riyad Said. Really, the cases are fantastic, excellent, And as Professor Shaheen mentioned, all of these are teaching cases with algorithm. And please don't, the key message, go step by step and you will reach the diagnosis. And reaching the diagnosis will put us on the straight way for treating our patients. Also, I'd like to thank and appreciate the presence of Professor Nagy Abdelhadi. Always we learn from Professor Nagy all the best. And I'd like to stop here, allowing some discussion if you have. Professor Nagy, do you like to add anything?
Actually, I would like to thank you very much, Hussein, and thank Professor Riyad and Professor Faissal. This fruitful night, actually, I enjoyed very much. I learned a lot from this presentation and this discussion. It was very good, actually. Thank you very much.
Really, it is fantastic. I found Professor Tail Baz. He is with us. Dr. Tariq, do you want to have a comment or adding any point? Dr. Tariq? Okay. So long as it is now 2 hours, I'd like to close the session by many thanks, Professor Riyad, for this night. Really, it's wonderful. And we have here in the chat many requests to add, to repeat the cases. We like the cases. So we'll arrange with Professor Riyad to have supplement of cases in near future, inshallah. And now
Well, thank you very much, Hussein.
The mic is to you, Professor Riyad, to close the session.
Well, I'd like to thank Dr. Nagy really being with us. I think his points were quite important. His comment was really highly appreciated, and I think it was to the point. I'd like to thank Dr. Faissal for his talk about what his experience about this trouble with the oil, dirty oil, that really being because of the ethylene glycol toxicity. And finally, I'd like to thank Hussein. You are doing a marvelous job, really, in keeping all this group together on, I think, every other day or on a weekly basis, at least for most of us. Thank you, Hussein, and I'm ready for anything in the future.
Inshallah.
Thank you, and good night.
I am very lucky to have this, to meet this gathering. So this is the symbol of love and respect for all of you. Thank you very much, dear professors and colleagues, and see you in next Friday, 48 hours, and we'll meet with Professor Ahmed Adam to discuss case scenarios and issues in renal biopsy, decision-making for renal biopsy.
That will be fantastic talk.
Okay, okay. Thank you very much, and goodbye.
Thank you. Bye-bye.
تصبحوا على خير.
أهلا أهلا.